Welcome to the session.
Yes, you're welcome. All right, okay. Alhamdulillah. Assalamu alaikum warahmatullahi wabarakatuh. Hello, can everyone hear me?
I can hear you, brother. Assalamu alaikum.
Wa alaikum assalam wa rahmatullahi wa barakatuh. You're very much welcome.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa rahmatullahi wa barakatuh. You're welcome. All right. Thank you very much. I think I'd just like to inform all of us that the program will start anywhere from now. We just want to allow some people to come in. It's just this is 2 minutes past 12. So by 12:05, so we want to give the first 5 minutes to allow people to settle in properly, so that we would start 12:05 on the dot. So we just want to allow people to come in, get themselves settled. So we would start the webinar from now. Thank you very much. So as we come in, you're welcome to Sakinah Medical Outreach quarterly webinar. So we're just trying to allow people to come in properly and settle down. Already we have 27 people now in the room, so you're very much welcome. Yes, I can see some names, I can see some people. I welcome all of you to this quarterly webinar. You're very much welcome. Thank you very much. I can cite the chairman of EPAC, Professor Kamari. You're very much welcome. Our guest speaker is already here. Professor Wale Sulaiman is here. You're very much welcome, sir.
Yeah, good morning, everybody. Good morning.
Good morning, sir. Yeah, good morning.
This is Dr. Kazim. It's Dr. Kazim that's talking, right?
Yes. Thank you very much, sir.
Yes. Good morning. Good morning. How are you?
Good morning, sir. I'm fine, sir.
Thank you.
Fine. Yes, sir. We just want to allow people 4 minutes. I would start.
I heard you. When I came in at 9, I heard at 12. I heard what you said in terms of till 12:05.
All right, sir. Okay. So, all right. Haja Zainalaya, please, you can help us mute the microphone. All right. This is 12:05. So, on behalf of Sakinah Medical Outreach, I want to welcome each and every one of us to this quarterly webinar of the outreach. It's a quarterly health talk, actually, and we've held series of sorts. It's one of a series of programs that we have at Sakinah Medical Outreach in order to reach out to the larger community and make a meaningful impact, touch many lives, and provide support to many people. There are so many activities and projects that Sakinah Medical Outreach undertakes. So, but then, before we move on, I would like to recognize the presence of different personalities that we have here at the moment. Currently, we have about 50 people already on this, platform. Yes. So we have different personalities already with us. Yes, first, I'd like to recognize the chairman of Sakinah Medical Outreach, a person of Dr. Salman Yusuf, who is the chairman of Sakinah Medical Outreach. At the same time, I also like to recognize the presence of Mr. Disu Kamar, the chairman of MPAC, which is Muslim Public Affairs Center, and trustee of Sakinah Medical Outreach. I would also like to recognize Mr. Amani Mamadou, another trustee of Sakinah Medical Outreach. At the same time, like I mentioned earlier, our guest speaker for today is also very much here with us, in person of Professor Wale Sulaiman. Also can cite Professor Taufik Ibrahim. I know it's not easy to be a professor, and many other distinguished personalities in our midst. You are very much welcome to this program, the quarterly health talk of Sakinah Medical Outreach. I also recognize the presence of Alhaja Rahmat Ebeyemi, another trustee of Sakinah Medical Outreach. All right, so for us to properly navigate today's health talk, I would like to welcome all of us again to this quarterly health talk. Like I said, we will take some opening remarks, after which we would also acknowledge the presence of our guest speaker. We'll take a citation, then we'll take the presentation itself, and at the same time, we would, after the presentation, I know some of us might have some questions because we are considering back pain management today, and I know some of us might have questions. So please let us mute our microphones. We are just joining in. Let us mute our microphones. Let us mute our microphones so that we don't get please. Whose microphone is on there? I will get, a call back from one of those that have just joined. In case our microphone is on, please, Shakir, let us mute our microphone. Mr. Shakir Ritaye Yusuf, please mute your microphone.
On the top of the say. On the top.
And Dr. you're muted.
All right, sorry.
You're muted. Yeah,
Thank you very much. Yeah, can you hear me now? All right,
yes.
Thank you very much. Okay, thank you very much. So like I was saying, so please, when we just come in, let us try to mute our microphones. I was trying to recognize the presence of some of our distinguished personalities. All of us are distinguished. So but we just have to recognize some people. I have recognized some. I also like to recognize Alhaji Abdulrahman Adoge, who is a board member of MPAC at the same time Sakinah Medical Outreach. Thank you very much. A member of the board of director of MPAC, Alhaji Abdulrahman Adoge, you're very much welcome. Thank you very much. Okay, so we'll first take, like I said, some opening remarks before we go into the talk itself, and we just want to do everything within an hour. So right now, we'll take the opening remark from the chairman of Sakinah Medical Outreach, in person of Dr. Salman Yusuf, who is a consultant neurosurgeon at the National Hospital in Abuja. Dr. Salman Yusuf, please, let's have your opening remarks. You're welcome.
Assalamu alaikum warahmatullahi wabarakatuh.
Wa alaikum assalam wa rahmatullahi wa barakatuh.
So thank Allah for this opportunity, and I thank everybody for finding time to attend this webinar with a lecture to be delivered by our erudite scholar and internationally renowned neurosurgeon, Professor Rafiu Olawale Sulaiman. And I also thank him for creating time to come and talk to us today. This is a program of Sakinah medical outreach to give public enlightenment to people in areas of important medical conditions. For today, we have chosen back pain. I'm sure almost everybody must have experienced back pain one time or the other. And there is no other person who can do justice to this among us other than Professor Wale Sulaiman, who has spent most of his professional medical life in the management of back pain and back pain research. So without wasting much time, the aim of today is to listen to him, to clear our doubts, and then to be able to manage our own personal back pain or to prevent us from having back pain and give proper advice to others who may need medical attention. So thank you all for attending, and I wish for us to have a successful deliberation today. Thank you.
All right. Thank you very much, sir. Okay, thank you very much, sir. All right. So that was the opening remark by the chairman of Sakinah Medical Outreach, in person of Dr. Salman Yusuf. He has told us about why we are doing this. And in case probably this is our first time, or some of us are meeting or attending the Sakinah Medical Outreach program. The program, Sakinah Medical Outreach, originated as an initiative of the Muslim Public Affairs Center, impact in 2009. It was conceived to deliver top-notch healthcare services and medical aid to all Nigerians in need, regardless of religious or ethnic affiliation. While the organization's headquarters is situated in Lagos, its impact extends across Nigeria, reaching communities in various regions. In 2017, Sakinah Medical Outreach was incorporated as an independent entity under the Corporate Affairs Commission. Today, with 15 years of service, more than 12,300 poor Nigerians have benefited from our free medical intervention. 72.6% of these beneficiaries were women and children, and about 42% of the patients received treatment outside Nigeria. Sakinah Medical Outreach has conducted more than 2,207 surgeries, Allah Akbar, and spent over 145 million naira so far for medical intervention. So that's just give us an idea of what we do at Sakinah Medical Outreach and how far we have been able to touch so many lives with activities. So by God's grace, right now we would be moving into the presentation for part, all right? But before then, like the chairman of Sakinah Medical Outreach has told us, our guest speaker for today is the renowned and revered Professor Rafiu. As he mentioned, I actually did not even have that before now. So now I got to know that he's Professor Rafiu Olawale Sulaiman. All right, so just for us to meet distinguished speaker, I would give us a brief and abridged summary of his profile. Yes, Professor Olawale Sulaiman, MD, PhD, CON, was identified in his career as an outstanding neurosurgeon, researcher, innovator, leader, and one of the most spine
Your
centers,
network is off.
neurosurgery, and neurocare under the
We couldn't hear what you said.
Oh, sorry, apologies for that. All right, okay. How about now, sir?
I can hear you now.
Better,
All right.
better now.
All right, thank you very much. Okay, so probably I'll take that again. Professor Wale Sulaiman, MD, PhD, CON, is, like I said, a renowned researcher, neurosurgeon, and was identified early in his career as an outstanding neurosurgeon, innovator, leader, and skilled physician executive. He designed, established, and managed one of the most comprehensive multidisciplinary spine centers, neurosurgery, and neuroscience programs in the United States of America. In less than 5 years, under the leadership of Professor Sulaiman, the program became recognized by United States News, US News, and World Report as one of the best 25 neuroscience programs in the United States and comprised a team of over 250 physicians and allied healthcare providers across Louisiana, Alabama, Mississippi, and Florida. These are, states in the United States of America. The annual revenue generated also grew to more than $500 million annually. So that's to tell you the kind of person that we have brought to discuss this health talk. And after over a decade of outstanding contributions to American healthcare leadership, neuroscience research, and clinical neurosurgery, Professor Sulaiman decided to explore how he could utilize his skills gained abroad to advance healthcare at home here in Nigeria. He and his wife, Mrs. Patricia Sulaiman, who is an accomplished nurse with a master's degree in public health and a graduate of Cornell University training in healthcare leadership and management. Together, both of them established RNZ Global Limited. RNZ Global is a Nigerian company focused on hospital development, management, and operations in sub-Saharan Africa. Digital health solution. Professor Sulaiman has received national and international awards in recognition of his professional accomplishment and philanthropic effort. Most prestigious amongst them is his conferment with one of the highest national honors in Nigeria, in the rank of the Commander of the Order of the Niger, CON, by President Muhammadu Buhari for his professional accomplishment, patriotism, and humanitarian services both in Nigeria and abroad. Distinguished ladies and gentlemen, brothers and sisters, I present to you Professor Abdurrafi Wale Sulaiman. Over to you, sir.
Good morning. Good morning. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam.
Wa alaikum salam.
Thank you so much. I'm honored and privileged to be here. I want to, first of all, acknowledge and recognize my good brother, Dr. Yusuf Salman, who is a colleague, somebody I've known for almost 2 decades now. He has had an outstanding career, and despite his busy schedule and hard work in both the public and private sector, he still has time to give back. So as the chairman of Sakinah Foundation, I congratulate you for an amazing work. You and your team for what you have done, for all your philanthropic efforts, for thousands of surgeries you've offered to help people that were in need, and for those people that you're still going to help in the future. May I reward you and your team abundantly. I must recognize Mr. Kamal Disu, who is a trailblazer, somebody who always leads by example. His passion for the well-being and welfare of our people is always palpable when you sit down with him. He just continues to do more and more for the development and emancipation and well-being of our people. So I say good morning to you, sir, and to all the other trustees on this Zoom meeting. Good morning, ladies and gentlemen, and all of you that have taken time to be here this morning. Professor Wale Sulaiman. My understanding of this presentation is to talk about a topic that I believe is actually a public health issue. And because it's so polished and so it's presented in such a way that it's a unique disease that only certain specialists can manage, it's often misunderstood. So, Dr. Kazim, thank you for being the host. I think my understanding is that this is supposed to be a question and answer session. So, I guess you lead.
Yes. Apologies for that. Yes, I know it is. I was only trying to get some things done at my end here. All right, sir. Thank you very much. Okay, so welcome, Professor Sulaiman. Looking at the fact that today we want to look at back pain. Back pain is something that is very is one of the oldest known ailments affecting humanity with its documentation dating back thousands of years. Ancient civilizations such as the Egyptians, Greeks, Chinese recorded instances of back pain and developed various treatments ranging from massages, herbal remedies to spinal manipulations. Over the centuries, our understanding of back pain has evolved significantly. The Middle Ages saw the rise of more structured anatomical studies, leading to a better understanding of the spine's role in overall health. With the advent of modern medicine and technology, we have uncovered the complex interplay of muscles, nerves, and bones that can lead to back pain. So that's why these advances for back pain remains a common condition, a common issue worldwide, affecting millions of people, causing significant discomfort and disability. So looking at its long history and prevalence, it's crucial for us to understand back pain from its roots, and that's why Sakinah Medical Outreach has deemed it fit that this quarter we want to devote today's health talk to discussing back pain. So, Prof, to start with, it is essential that we understand the root cause of back pain and which is necessary for us to effectively manage it. So I would begin by asking, what are the most common causes of back pain and how can individuals identify the sources of their pain?
Well, thank you very much. So I think it's important. I made a statement when I started that I see back pain as a public health issue. And what I mean by that is, it's not a surgical disease, it's not a predominantly medical disease, it's not something that any specialty would take only the forefront. It takes it to be able to manage. There are many dimensions to it, it's complex, and it's very common. So if you take any population, 70 to 80% of any population will have issue with back pain in lifetime, which means that any population you take, if you take 100 people, 70 to 80 of them in their lifetime will have some degree of back pain. So we talk about incidence and prevalence. So at the snapshot, if we take a population, 70%, 60 to 70% in terms of incidence will have back issues. Then if you look at a lifetime, about 80%, which means 80 out of 100 will have back issues. Now, most fortunately for us, most of them are benign. Most of them are benign. They really don't need aggressive intervention. Most of them just need some medical management, lifestyle modification, and also maybe some interventions, not necessarily surgery. So I say it's a public health issue because as a public health officer, you're better off investing in things that can prevent, that can have impact on the incidence and prevalence of back pain. So that way, because the cost of managing what may happen in the future is significantly higher than instituting public health policies that will help people. In terms of the causes of back pain, there are, we can categorize them into two categories. There's the modifiable risk factors and the non-modifiable risk factors. The non-modifiable risk factor, which is the one that it is what it is. So one of them is age. So when we say lumbar spondylosis is essentially a fancy word for arthritis of the lumbar spine, or thoracolumbar or cervical spondylosis is a fancy word for arthritis of the spinal column. And it just means wear and tear. So as we age, a lot of things happens to our body in terms of the musculoskeletal system. So it means that arthritis of the hip, of the knee, and the wrist, finger joints. That also happens in the spinal column. So lumbar spondylosis is wear and tear, which means there's degeneration of the disc, which affects the joint, which then affects spinal muscle spasms, which then affects posture, which then generates a very complex interplay of multiple pain generators. So there's age, so female versus male. There's a familial predisposition. There's a family factor in terms of if you have a family history of back issues. Those are things you can't modify. And of course, there's some people that have a genetic syndrome that unfortunately they have a syndromic diagnosis. Then there's the modifiable risk factors, which has to do with things that we can control. And one that is very obscure that people don't think about is smoking. I think there's a lot of campaigns against smoking now. So the most common one is body weight, obesity, smoking, sedentary lifestyle, obviously your occupational hazards, and of course, then we think of things like trauma. And then there are people that have chronic ailments that may predispose them to spine infection, which is diabetes and some autoimmune diseases. So those are the things. Then we then begin to kind of look at, okay, when you look at the modifiable one, which is what we can focus on to try and help people to prevent themselves from experiencing devastating back pain. I hope that answered your question.
Yeah, very much so, very much so. Thank you very much for that. But for the fact that you mentioned that of age, obesity, a sedentary nature of people sitting too much and things like that, based on the nature of their work, things that I believe that for a lot of people that are listening now, at least, is to make them understand some of the things that could actually cause, this condition. And like you said, it's not a surgical issue, but then more about probably even sometimes our lifestyle, like including even smoking that you talked about. A lot of people probably might find that surprising that it could actually lead to this condition that we call back pain. Now, so can you probably intimate us about the different kinds of back pains that we have and how we can actually treat them? Because people talk about acute, they talk about chronic back pain. So what exactly are different types of back pains that we might have, and how do we approach addressing or treating these conditions separately?
So that's a great question, because identifying back pain on time, a timely intervention, and making sure you prescribe the right treatment will prevent people from becoming chronic pain patients, chronic back pain patients. So there's what we call acute back pain, which is, these times are kind of variable. Typically, you say between 0 to 4 weeks is acute back pain, between 4 to 12 weeks is subacute, and then after 12 weeks, it becomes a chronic back pain. So, and a lot of what, so there is the concept of the acute back pain that is triggered by activity, which means maybe you're moving house, lifting something heavy, all of a sudden you have acute back and leg pain, which is called sciatica. That's triggered by an activity, or there's a fall, you fall from the height and then you break your spine, or you're involved in a motor vehicle accident. Those are things that can lead to either devastating neurologic issues, including back pain, or there's acute back pain that give you lower back and leg pain. So that one is the one that we need to, especially the one that is induced by minor trauma, which means you're moving house or you kind of trip and you have back pain. So intervening on time to use the correct regimen of medical management, as well as sometimes some physiotherapy, some maybe spinal injections and things like that to make sure you can abort the acute pain is very critical. Then you have a second chance in the subacute part of the subacute category, which means that the medications you use in the acute phase, if they're not effective, then you need to kind of change them around to be able to really stop the pain. Because when it becomes chronic pain after about 3 months, there is a physical component of pain, and there's a psychological component of pain, which was very complex brain pathways. And if you don't manage acute to subacute pain effectively, then people become chronic pain, which becomes very difficult the longer it takes in terms of people can begin to have very complex issues with pain because then there's a psychological component that's difficult to manage. So that's the different types that that we talk about. So
All right.
for acute pain, interestingly, I think there are 3 things we try to manage, of course. So there's the pain itself, which is nociceptive pain, and then there's the inflammation. And then when you have pain, you can see when you've seen somebody with back pain, they tend to guard, which means they turn away from where they're coming from. And then that leads to excessive muscle spasm. And then, of course, there's what do you do with the activity? In terms of acute pain, believe it or not, some of the most effective medication, they're not the strong pain medications. They're not narcotics. They're actually non-steroidal anti-inflammatory medication, what we call NSAID, anti-inflammatory medication, ibuprofen, naproxen. Sometimes we use steroid, which is a strong anti-inflammatory medication. And then if you can do that in a timely fashion to abort the inflammation, then you can combine that with some pain medication, not necessarily narcotic. It can be paracetamol, it can be acetaminophen, what we call Tylenol. And at the same time, when you feel like there's reduced mobility or maybe movement of the lower back, you can then add some muscle relaxant. You do that, and the critical point here is that the patient must comply 100% with how the medication is being prescribed. You can't take it and then you feel better, then you stop. If we say take it for 2 weeks, you must take it for 2 weeks. If you start an anti-inflammatory medication and you stop it, the inflammation will go back, because it's like chasing your tail. So you need to take it until you complete the course of treatment. Then in the subacute phase, if the pain continues, then we modify it to be able to now make sure we can begin to transition a little bit from the anti-inflammatory to just maybe some pain medication that's needed and continuation of muscle relaxant that's needed. Hello, go ahead. Dr.
All right,
Kazim.
thank you very much, sir. Yeah, thank you very much, sir. All right. So I love the fact that you explained to us the different kinds of back pain that we have: the acute, self-acute, and the chronic one. And for the fact that we need to actually stay on course with our medication and whatever guidelines have been given to us. Now, also, Prof, so what are some of the lesser known risk factors for developing back pain, especially for those who may not be aware that they are at risk? Because a lot of times, so people might just feel it's just something slight and they overlook it. And before you know it, it grows from just being an acute to probably self-acute or even to the level of chronic. So are there some other, lesser known risk factors that could actually lead people to developing back pain?
Well, I mean, I think, so if you look at pre-industrialization, right? A lot of our forefathers and then our parents, back in the days, they led a very active life because they worked on the farms, they worked on the grounds, they were very active. And there was not this easy access to mobilization, to this means of transportation. So and that helped them to be able to maintain the body weight. They were significantly active, and so they didn't gain a lot of weight. They were very active. They would go to the farm, they would come back. So, and they ate fresh food and non-processed food, and obesity was not an issue. But where we are now with industrialization and access to this fast food, obesity is a significant issue in our society because we lead a very sedentary lifestyle. We eat junk food. We don't exercise. And that by itself it's a significant risk. And I'm very worried that in the next 20 to 30 years, we're seeing it already. There's a significant increase in the incidence of pediatric childhood obesity because of all these fast food we're feeding our kids. So maintaining body weight. The second one is obviously ergonomics and posture. And so it's for the obesity, and it doesn't have to be, you don't have to be a gym freak to maintain your weight. It just means that you have to make sure that your exercise is commensurate to your intake, which means that even if it's just 30 to 15, 20 minutes a day to be active, so that way you are exercising your muscles. And there's some a range of motion, some physical stretching exercises that you can do to make sure that you maintain your back head. Ergonomics is very important because a lot of with this modern technology with cell phones and laptops and iPad, we tend to kind of just sit in one place and playing on all these gadgets. So moving around, getting frequently, and making sure that your computer is at the level of the eyes. So your workplace, making sure the chairs maintain your lumbar posture and you can stay sitting upright, you're not slouching, and go and so on and so forth. So people focus in the ergonomics and occupational health of the people that we employ or the employers themselves is very critical. So that's the second one, making sure posture. And then the third one is people that have chronic ailments, diabetes and people that unfortunately may have cancer and on immunosuppressants. We need to make sure we're keeping it top of mind that they are at higher risk of infections that may cause a lot of trouble. And people that have cancer can go to the spine, and that can cause devastating neurologic issues as well. Obviously, we can't say this without talking about, of course, motor vehicle trauma, as you know, in terms of what we can do to prevent some of the devastating spinal injuries from that. So lesser ones, they're not lesser, but they're very critical for people to pay attention to, is your body weight. Just make sure you don't begin to.
All right, sir. Thank you very much, sir. I love the fact that you touch on the aspect of body weight, especially with the fact that with the kind of food that people take in now and the kind of lifestyle where people don't actually exercise a lot, they don't have the opportunity of walking over long distances or even short distances. Any little thing, you jump in your car and you zoom off and things like that. So people really don't have the time to exercise. So it makes people not pay attention a lot to their body weight. All right. So, and that is actually, that predisposes them to this condition that we know as back pain. So now, Prof, in a case where people now, for a long time, they actually don't treat or they poorly manage the incidence of back pain. So what are the potential long-term health consequences by the time you have it and you feel like it's normal, probably because of the nature of the work that I do or the way I see it. That's why. So it's not something that I really need to pay attention to. So are there long-term consequences of untreated or poorly managed back pain conditions?
Well, I mean, I think if you have back pain, like I said, is acute, subacute, and chronic. And the easiest one to manage, if managed properly, is the acute phase. You manage acute back pain well, then you reduce the number of people that will go from the category of incidence of back pain to the prevalence of back pain. Because then you don't manage acute, they become subacute and chronic, and then you increase the number of people in your population with chronic back pain. Now, chronic back pain is very difficult to treat. The one that the surgeons treat is mechanical back pain, which is, is a handful of patients that are qualified to do that. So if you don't treat the pain on time, then obviously the pain will increase, and then you become chronic pain patient. And there's a lot of health consequences of that because it becomes a vicious cycle in the sense that in pain, you can't have this physical activity, you gain weight. With obesity comes multiple medical problems, diabetes, hypertension, heart disease. You can live out perfect, then your cholesterol goes up, and so on and so forth. So the things that we are not good at measuring yet, but chronic pain leads to a lot of health challenges through obesity. And then the third one is the psychological aspect of it. It just once you don't manage acute pain or subacute pain, then the psychosomatic part of back pain becomes very challenging. Because people can feel defeated, people can feel like, deflated or even lose ambition to do anything. And then, of course, there's a very small portion of 1% of people that have secondary gains. They just don't want to get better, but that's a very small percentage. But most people don't feel like, maybe they're young, they're in a lot of pain, they don't understand it. Why am I having to deal with this? I'm a very young person. And a lot of it is just getting to the right specialist to manage them. So psychological aspect of pain. And then if it's a back pain that's caused by, let's say, infection, spinal tumors, or a trauma, or minor or major trauma that's led to back and leg pain, if you don't treat it, when the nerve is injured, it causes 3 different types of symptoms. There's pain, there's sensory changes, which is numbness, tingling, and things like that. And then there is changes to the motor function, which is movement of muscles. So if left untreated and there's compression of nerves, then what will happen is that you could lose some function in terms of being able to move. And then sometimes you can lose control of your bladder and your bowel. So those are these, and in the last result is also you begin to develop some spinal deformity if the initial cause of the problem is infection or spinal tumors or trauma. Thank you very much.
Hello, Prof.
Yes, sir.
Hello, Prof.
Yes, sir.
Down for
Hello?
the
Yes.
enlightened
Yes, sir. Thank you very much, sir.
discussion. I'm hearing you for the first time. I don't know whether it is the same Professor Wale Suleiman that
But
came
please,
to
sir, the
contest this.
presentation is still going on, sir. Please, sir. Please, sir. Just hold on, sir. Please, sir. Please, sir. Just hold on, sir. The engagement is still on. There will still be room for feedbacks and comments and questions. So please, let's just hold on, please. All right. Thank you very much. All right. Thank you very much for the answer that you gave concerning the long-term consequences of untreated or poorly managed back pain issues. Like, I never knew it could even result into deformity or inability to move or the loss of control of the bladder and bowel. But that is something very, very critical that we all need to pay attention to. Okay, now we need to probably move on now, and we're looking at management of back pain now. The next question I have here is, considering the fact that you mentioned the issue of our diet and exercise, so what contribution do they have in the prevention or management of back pain, the issue of exercise and diet specifically? So thereafter, we'll now talk about the issue of our posture. So, but let's first talk about diet and exercise in the management of back pain. So,
well, I mean, I think we touched some of these already. I think because all these topics are kind of joined together. I think, again, I will emphasize that, most people are afraid to exercise because they think they have to do a lot. And what you need is just 15 to 30 minutes on a daily basis, or even 3 to 4 times a week, of either going for a walk or on a stationary bike or treadmill, or just moving. You need to just get up and move. By the time you're sitting down for 1 or 2 hours, if you have a chance, get up and just stretch your legs and move around. That's important. More specifically, the issue of truncal obesity, which is what we call pot belly, is very important. So the way you should think about the spine carries the body. So the spine is like, I always give this analogy of, let's say you've gone to do grocery shopping, you've gone to the market to buy food, and you have 2 bags, and you're carrying, and one of them is 10 kg each or 5 kg as you're carrying it. When you get home, and it's people a lot of weight on your back. When you get home and you just drop the grocery bags, and you feel better, like, oh my God, that was so heavy. So that's the same thing about what happens to your spine when you gain weight. There are a lot of patients that they have a lot of back pain and they are overweight, not necessarily morbidly obese, and they lose about 2 to 3 or 5 kg and the back pain goes away because the spine is like a shock absorber. It's one that carries most of our body weight. So the less you load the spine by losing weight or not gaining weight, the better for you. So that's very critical. And then, and like I said, 15, 30 minutes a day or 3 to 4 times a week is sufficient. Obviously, you need to also maintain good diet, which means diet and exercise, which means you need to consume your vegetables and fruits and make sure you have components of the good nutrition in your diet. And then so you diet, exercise, and I think that the ergonomics cannot be overemphasized in terms of posture, which means when you're either sitting down to eat dinner, we always, these days we don't do that anymore, but the concept, okay, just put your shoulder up and sit down properly too. We all slouch. And when you slouch, you're struggling, you're fighting the normal curvature of the spine. So that's why sometimes when you sit in your car, put a little pillow behind your back to maintain your lumbar lordosis. The more you cause the spine to move opposite the normal curvature, the more the muscles will go into spasm, the more you're stretching the joints, which we call the facet joints, and that causes a lot of very complex relationships in the spine. So for those that have back pain, I think back in the days, just sit in the bed, just relax, just rest. If you're in severe pain, of course, you need to get treated. And then once your pain is better, the quicker you move, the better you're going to feel. We don't put people to bed rest for months or weeks anymore. We don't do that anymore. That used to be done decades ago. We want you to be active. We want to treat your pain as aggressively as we can. We need you to move. And we need, so those are, so lifestyle modification with regards to diet, it's as nutrition, and then staying active, and also making sure you maintain good postures and pay attention to the ergonomics of your workplace.
All right, thank you very much, sir. All right, so talking about non-surgical treatment, like physical therapy, acupuncture, and chiropractic care in managing back pain, how effective are these measures for?
There's an algorithm, right? And there's the first tier, second tier, and third tier. I think I'm just going to put in the layman's term, though. So when there's back pain, there are a few things that are going on, okay? And so if we can understand why you have back pain, which means maybe you're lifting something, then all of a sudden you have acute back pain that's either radiating or not radiating. If you have acute back pain, whether you slept funny or you're lifting something, and then you just have lower back pain that doesn't radiate to your leg, we don't even do images anymore. The recommendation is just give some anti-inflammatory, some muscle relaxant, maybe steroid, and get the pain, acute inflammation to reduce and control the pain. And most people will get better, 70–80% will get better. Now, if that doesn't help, then you can add some maybe strong pain medication, and then, but once you have acute back pain and it radiates to your leg, which means you have radiculopathy, then we begin to say you need an MRI to look at what's going on, to see where the compression is of the nerve. That's with sciatica. And even that, when you have back pain with sciatica, we don't get an MRI urgently unless you have weakness or some bladder and bowel problems. We can still manage you with medications. If the medication don't improve the pain, then we order an MRI to see what's going on. So I think medication, then the next set of intervention when we've tried medications, anti-inflammatory, pain medication, and muscle relaxants. When we've tried that, if you're still in a significant amount of pain, we change the medication, but we begin to now say, okay, your pain is better controlled, you can do physical activity now, which comes into physiotherapy. Now, the problem with physiotherapy is that it's not standardized. So there are some standard protocols that must be used for back pain, depending on the nature of the back pain, depending on what you want to target, which muscles are contracted, which muscles are weak, and all these things. Well, most importantly is the core muscle strengthening. That's what I said. You can avoid pot belly, avoid it. So if you can strengthen your core, it just provides a balance between paraspinal muscles and abdominal muscles so that you can maintain a good posture. Things like, then of course, we still need to kind of get you to a better place. We do spinal epidural injections. What that does is that instead of taking the time to go through your bloodstream to the nerves and to the muscles, we can inject a combination of strong anti-inflammatory, which is a steroid, with a local anesthetic, and that controls the pain. About 60–70% of the time. You can get it 3 to 4 times a year, and that's its fixed. And then things like, there's so many pain generators in the back. There are tissues, things that can cause pain in the back. You have muscles, you have ligaments, you have tendons, you have bone, you have facet capsule, you have the dura, you have whether or not the disc space, and so and bone. So there's so many things that can cause back pain. So it's just a matter of just teasing it out to understand what is predominant. You may not know, but what's the predominant cause of back pain? So for instance, the neurosurgeon will be looking at, okay, can I identify something that's compressing the nerve that I can treat surgically to be able to improvement in pain if medication doesn't help? So acupuncture, chiropractic manipulation tries to realign the spine and do some manipulation to ensure there's a balance between potential causes of the pain. And it has its role in terms, especially in the lumbar spine. In the cervical spine, I think the role should be limited because of the potential side effects in terms of manipulation of the neck. It's so fragile. But mild traction of the cervical spine may work, but in terms of aggressive manipulation, probably in terms of chiropractic manipulation, probably more the lower back than any other place. Acupuncture, massage, and all those things, they tend to kind of address generators as well. I think there's no one treatment modality, especially when you get to the chronic pain frame category, that is the panacea. You have to use a combination of different modalities to get a patient better. The level of evidence to support one or the other is varies, but sometimes it's hard to get stronger evidence to support what we do. So those are and then of course surgical management at the end if needed.
All right, thank you very much. So
Good morning.
it means that there are different levels of this condition that will determine the kind of intervention that would have to follow. Thank you very much, Paul. So now, considering the fact that, so in all of this, at what point should a person consider seeing a specialist? Consider that at this juncture, probably I need a neurosurgeon, I need this person. So at what point or what symptom would indicate that it's time for more in-depth evaluation of that particular condition? So at what point? For an individual, because our levels of endurance, of pain, and other things, differ. So, and for the fact that based on experience, through different experiences, at a particular point, someone will consider a particular pain as acute. Some might say, okay, this is self-acute, or probably this is now more chronic. But then, so at what point should an individual consider seeing a specialist for any of these conditions?
My doctor will tell you.
So, in your introduction, when you read my citation, you said I started one of the most comprehensive back and spine programs in North America. So my ideal, I think this can be applied to any field of medicine, really. Because patients don't care what your title is, whether you're a neurosurgeon, neurologist, or a GP. They just want to get better. So what we did in New Orleans is that we said, look, can we create a one-stop shop whereby all the people that are involved, all the specialists that are involved in management of back pain can be working together to make sure the patient sees the most appropriate provider the first time around. So we have an algorithm. You have back pain without leg pain, you could see your GP, which means your primary care physician will see prescribe, there's a treatment algorithm, you prescribe all the medications you need. If you don't get better, or you begin to have leg pain, he can also send you for an MRI. And then if something that doesn't show surgical pathology, then you probably need to see maybe a pain management doctor or a rehab doctor or a physiotherapist to manage that. But the setup is different in our own environment here in Nigeria. So I think when the time you should be worried are number one, which we call dangerous back pain. Number one, if you have back pain that radiates to the leg, that is not relenting, then you might want to see a neurosurgeon. And number two, if you have back pain that's resulting in some kind of loss of control of blood and bowel, you should probably try and see a neurosurgeon as soon as possible. Number three, if you have back pain that's leading to progressive sensory dysfunction, which means numbness, tingling, and just unrelenting pain, you should see a neurosurgeon. Number four, I think that back pain that are present at rest, which you're lying down and you're not loading your spine, you're not really sitting up and you're having pain. Those are very concerning. I think you should see somebody urgently. Number six, back pain that are associated with fever and chills and not present at rest, you should probably be seeing somebody urgently. The other one is weight loss, especially if you have a diagnosis of malignancy or you're just losing a lot of weight and then you're also associated with back pain. I think you want to be able to be looking to see somebody. If you have been involved in a motor vehicle accident and you walk away from the scene for subsequent days, you're now beginning to have significant pain. You may have had a minor trauma that's been exacerbated because you've not had the right treatment. You need to see somebody after a fall, motor vehicle accident, something like that. So those are some examples of things that will raise alarm in terms of when you need to see a spine surgeon to at least review you and make recommendations of what needs to be treated. So those are what we call dangerous back pain.
Thank you very much, sir. I love some of these, how do I put it, symptoms or points.
Sorry, let me just say one more thing. Sorry, just let me say one more thing. Because of the peculiarity of our population, we have a lot of people with diabetes in society. So if you're a diabetic patient and you're having unrelenting back pain, please just go and see somebody to make sure you don't have any kind of infection or something. Please, I just wanted to add that. If you're a diabetic patient or if you're on dialysis or you're taking continuous IV treatment for something, please, if you haven't come back, then you should see something. Thank you.
All right, sir. Thank you very much, sir. All right, probably very quickly now. So I want you to probably tell us how the importance of educating patients, patients in the management of back pain and what key information should patients know to better manage their condition. So the importance of education of patients now in managing this condition of back pain. So how important is that?
I think everything we do in medicine, so what we kind of we're doing when we treat patients, we're trying to fight with the natural history of the disease. So when we're treating hypertension, we say we treat hypertension. If you don't treat it, you could have a stroke, you could have a heart attack, so that there's a natural history over time of what happens. So the same thing with back pain. I've just described acute, subacute, chronic, and some potential injuries could happen. So you have to be able to describe the natural history of the disease you're treating to a patient. So look, these are the issues that are going on. This is what is causing it. This is what we need to do, and this is why you should do it. And that way, the decision is really a joint decision between the patient and the patient, because otherwise compliance becomes an issue. If the patients don't understand what's going on, they're fed with a lot inaccurate and incomplete information, and that can lead to a lot of dangerous things. So educating the patient, saying, this is your diagnosis, this is what can happen if we don't treat it, and know so that they will understand why, because we want to prevent bad things from happening or worsening symptoms. So it's very important. Otherwise, compliance is difficult. They won't be compliant.
All right. Thank you very much. So compliance will be very difficult if we actually don't give adequate education to people. On a final note now, before I take some questions, so many questions are coming. So what advice would you give to someone, for instance, that is currently experiencing back pain and does not want it to become severe or chronic? So what advice would you give to people generally now that are experiencing back pain on a final note, sir?
I think you should see somebody. I think that the challenge we have is access, right? We don't have enough doctors to manage all the back pain we have. So I think if you haven't just back pain that is on, so all of us have back pain. Like I said, 80% prevalence in terms of 70 to 80% prevalence in terms of people having aches and pains, and that's normal. That's just part of, we all get older, we will have aches and pains, and that's not something to should raise alarm. It is an unrelenting, agonizing. So if you have back pain and something that aches and pains, if you stretch or you kind of move a little bit, it will get better. If you have back pain that is of aches and pains, and if it's not getting better with stretching, then you can take some, ibuprofen or something. Especially if you're educated and you understand those things. If it doesn't get better, the next thing to do is to see a doctor. See a doctor. And if you're not happy with the doctor that you're seeing, then you need to see a specialist to better understanding. And I think I've described AGO in terms of what pains to be worried about. And if you have those, you should insist to see a spine surgeon.
All right. So thank you very much, sir. Thank you very much for the answers that you have given to all these questions. So right now, it will be time for the members of the audience to ask their questions. Some questions have already been forwarded to me that are available. So, but before I take those ones, I would just want to find out from a whole lot of people, from those of us that are here. Okay. Okay. So some of those questions have actually been taken from the chat. So, but from the general participants now, we have about 139 of us on this platform right now. So if there is anyone that has a question, you can actually raise your hand. I would recognize you, and we'll do that. I'll take those ones that are available. So please just raise your hands. I'll recognize you. Then I'll also take some questions that we have in the chat, box. So, but if you want to ask your question physically, apart from the ones that you have sent to the chat box, please you can do by signify by raising a hand. You can always do that under the reaction, icon to raise your hand. So please let's do that. But while we are waiting for that, let me take some of those questions that we already have in the chat, which have been forwarded to me. One is, Prof, please, can physiotherapy correct and reduce pains around the waist and legs and inflammations at the calf owing to an herniated disc at the waist? Wow. Prof, I don't know if I told you about that.
Yes, I got it.
I have taken notes. Yes, I'll get to you, but let Prof answer that, please.
No, I think physiotherapy is part of the treatment algorithm for acute pain, back leg pain. But if you have unrelenting back and leg pain after sessions of physiotherapy, then you should probably find out what's going on, and you may have to go to the next phase of treatment, which is injection or even surgery. So I think that's that.
All right, thank you very much, sir.
It's important that the physiotherapy includes traction if you're having leg pain and core muscle strengthening.
That is referred to the armpits and chest. Why are we seeing increasing cases of spondylosis, and how can we prevent them? So let's take those two. What are the causes of upper back pain that's referred to or that cause around the armpits and chest? What could be the cause of upper back pain? And the second one, why are we seeing increasing cases of spondylosis, and how can we prevent them? Yes. Prof.
Yeah, can you hear me? I mean, I think you have to be careful now in terms of when you have pain referring to your chest. You have to make sure it's not something coming from the heart or cardiac issues and something with the chest. It's typically arm pain that are related to the spine. They tend to originate from the neck and then they radiate towards your shoulder and then to different parts of the arm. So it's what we call cervical spondylosis with radiculopathy. That's different. Chest pain, please make sure you rule out cardiac issues before you ascribe it to cervical spine. And then the one with the neck pain, typically when you move towards the side of the pain will get worse. So you can get I think we've talked about why we're having an increase in incidence of back pain. Lifestyle, if with some of our people don't even carry their own bag. They don't even carry their own bag anymore. Everything is carried for you. You have a driver, you go from house to work, you sit down all day, then you go to your table, you eat your food, you just feel the big manism is causing a lot of our health issues and a lot of obesity and in a sedentary lifestyle. And that's not good for us. That's not good for us. There's no big deal in getting up and going to get your own cup of coffee every now and then, especially if you've been sitting down for a long time. You need to be more active. That's the bottom line.
All right. Thank you. We need to be more active, and that's something that we really need to pay attention to. Okay. All right. So what are the causes in people that are under 50 years? Comment. That's one. And then this one, anytime I take sugar, I usually experience back waist pain. What can I do, sir? Back waist pain anytime the person takes sugar, and probably the causes and treatment of lower back pain in people that are under 50 years. So since we said age is one of the factors that predisposes people to back pain, then we now have cases in people under 50 years. So the causes and treatment and the issue of taking sugar with lower back, back waist pain. Prof. Hello, sir.
I think we lost him. We have to just wait a little. Let God connect.
Okay, let's just hold on.
Assalamu alaikum.
Wa alaikum assalam.
While we are
We're
waiting
still
for
trying to
him,
hold on. Okay, okay.
can I quickly subscribe to the question of chest pain?
Okay, Prof.
I think it's back. I think it's back. All right.
Okay,
Thank
sir.
you.
Yes, sir. So, Prof, sir. The network is kind of funny, and it's affecting the audio quality.
Well, if you still don't have him, as a cardiologist, can I throw more light on the question of chest pain and arthritis?
In the meantime, sir. All right, sir. You can go ahead. While we.
Thank you very much. Right. Yes, from our experience, somebody with.
But in the meantime, please, may we know who is speaking, please, because the name is not showing. It's just showing Excel.
Oh, sorry about that. My name is Professor Katibi Ibrahim. a consultant cardiologist and professor of medicine from University of Ilorin Teaching Hospital.
All right, sir.
I listened, to the discussion, and I had the question regarding chest pain and arthritis. And I had the speaker warning that the two should not be confused with each other. Somebody with chest pain that is from heart-related problems, specifically that is from ischemic heart diseases, most likely the pain will be effort-related or exertion-related, as against the pain that is from arthritis, which is usually even arthritis. And then usually the individuals will have some other background illnesses that will have predisposed him or her to ischemic heart disease or coronary artery diseases. This may include such things as being hypertensive, being diabetic, or having dyslipidemias, abnormal cholesterol in circulation, and so on and so forth. So a lot of the time, somebody with straightforward costochondritis may present as if it is chest pain from coronary artery diseases. But when you take the step to see your physician and they run basic tests on you, for example, resting ECG, which is just for 5 minutes, if it is coronary artery disease, you will see changes on the ECG that will be suggestive of coronary artery disease. And if that is still not conclusive, you can take a further step by requesting for a treadmill ECG on the patient. So it is usually not difficult to distinguish between chest pain from arthritis, as in costochondritis, and chest pain from coronary artery diseases, which is more fatal. Why arthritis may not kill immediately. If you miss coronary artery disease and it progresses further, the patient may actually end up dying in the process. That is why it is important to make that contrast distinction between the two and offer them appropriate treatment. Luckily, both of them have specific form of treatment, and they can be eminently cured in both instances. I don't know if he's back now. If he's not back, I can still say
I'm
for that.
connecting on my phone because the network.
Okay.
Oh, I see.
But I can hear you.
You're welcome
I
back.
just don't want to mess up the network by turning on my camera. I can hear you.
All right, sir. All right, sir. Okay, sir. All right. So there was a subsisting question on having someone who experiences back waist pain whenever he or she takes sugar, and talking about what could be the cause of back pain or lower back pain for someone that is under 50 years.
Well, I think we have talked about this. I think there are two things I would emphasize: obesity, and then in my career, I have hardly ever operated on patients below 40 years old. But the times that I've had to do it is been in patients that smoke. So smoking is one of the so inactivity in terms of obesity, and then smoking. Sedentary lifestyle and smoking, they're so bad for your spine health. Smoking cuts up the blood supply to the spine and essentially accelerates the degenerative process of the spine. So when I see patients in their 30s and 40s with spine problems, the smokers, or they are obese, or they are inactive, or they are involved in at labor that they are not taught how to properly lift or bend to lift with their legs, not your back, and those kind of workplace safety measures that should be taken. Sugar, I don't know that that's related to. I don't know that those two things are related. I can't explain that.
All right, sir. Okay. So we have some people that raise their hands on the platform. Mr. Isa Ibitai Ibrahim, are you there? You can unmute yourself and ask your question, Mr. Isa Ibitai Ibrahim. Okay, if Mr. Isa Ibitai Ibrahim is not okay, yes.
Thank you.
Go ahead. Yes, sir.
Mr. Ibrahim is my name. I do have back pain. And each time I have back pain, I go to the hospital. And when I seek that medical advice, one of the drugs that have always been prescribed for me is diclofenac. And I was advised that I should take less of diclofenac, that is very dangerous. In such a circumstance, what advice can you give to me, sir? So that I don't run from fire to fire.
To fire. All right.
Yeah.
Thank you very much.
Yeah, that's a great question, and I think that you remember that when we talked about management of acute back pain, that typically the mainstay of management is anti-inflammatory, which is diclofenac. Now, diclofenac has two major risk factors that we talk about. There's others, which is it can irritate your stomach and then it can affect your kidney. So, but if you take it for a short period of time, 7 to 10 days, if your pain is acute, you don't have a history of kidney problems or ulcers, is generally very safe. And it's when people don't comply fully with the regimen in terms of take the medication once or twice a day, every day, whether you have pain or not, for a period of 7 to 10 days, that's when they keep chasing their tail. Most people will take medication prescribed for 2 days and then stop, I feel better. But you may feel better, but inflammation is still there. So it's good to fully take the medications, finish the course of the medication. That way you don't have to keep going back because you have not been compliant. So that's I think, and I think if your pain is recurrent, then perhaps there's an investigation that needs to be done besides X-ray, maybe an MRI. They just make sure something more dangerous or more serious is going on. Probably not, but I think if you're having to go back to the emergency room, then perhaps something more should be done. Thank you.
All right. Idris Alao, please, are you still there? You can ask your question. You also raise your hand.
Yes, thank you very much. I want to know the best approach to go with back pain emanating from working on the laptop. I work on the system, and even though I try to take some breaks because I learned that it's not good to remain in one spot for say 30 minutes or an hour. It's always good to walk around and come back. But at times it's not recurrent, but I feel it once in a while. It comes and goes. Am I to take just a painkiller, or what am I to do?
All right.
Well, that's a great question. I think I think I mentioned some of these. Obviously, the most important thing is when you sit down, make sure that you have back support, especially if you're sitting down for a long time. Make sure you sit up.
Hello, Prof. Hello, Prof. Prof, we can't hear you again. I think the network seems to be playing like a fast on Prof just now. So hold on.
Can you hear me?
Okay, yes, we can hear you now. We can hear you now.
Yeah, it's a Nigerian factor, but we have this. They have this desk now that actually you can stand up. You can raise them up. So if you're working a lot on a laptop, maybe you might want to get this height adjustable.
All right. Okay. Thank you.
I didn't get him. I didn't get his last part of the response. You said to get a height adjustable something. I can't. What did he say?
Okay.
Adjust your seat.
There are those chairs that you can adjust your height so that you.
Okay.
Right.
Okay. Oh, thank you.
Okay. Hasna Abu, one of those that raised, their hands. Please, are you still there?
Yes, I'm here. Good afternoon.
All right. Good afternoon. Yes, you're welcome. Please, your question.
Thank you for this webinar. It was quite insightful. Thank you very much.
You're welcome.
So I have several
You're
questions.
welcome.
The first one is, first of all, I'm a 28-year-old diagnosed with lumbar and lower thoracic spondylosis. Fortunately, I don't have any disc herniation, but I have osteophytes all the way from my lower thoracic segment down to my down to my lumbar segment all the way through. So my doctor, the neurologist I saw earlier mentioned that the osteophytes are not reversible. But after I started going for physiotherapy, the physiotherapist told me that the osteophytes might be reversed, being that I'm still young. Maybe young age is still on my side, since usually the people that have this disease are older people. So I might actually get better with physiotherapy or something. I don't know how true that is. So the second question, sorry? Okay, my second question is regarding, because mine radiates down to my legs. I have burning sensation on my legs, and then of late I have been having swollen knees. So an orthopedic doctor I saw told me that it's early signs of osteoarthritis. But he said that if I manage it well, it can be reversed. So now my third question is, please, how do I book a consultation with Dr. Wale, please? A direct consultation, if possible. Thank you.
So, how old are you, ma'am?
I'm 28, sir.
Do you have, is there a family history of spine problems or things like that?
Not at all. And I also was not involved in any trauma, any accident. It's I think it happened due to the nature of my job. I'm a makeup artist, so I stand for at least 12 to 14 hours straight with no breaks. And I've been doing this for about 11 years. So I think that might be the cause.
Okay, so it depends. It's the nature of your job. So
yes,
I think that the best thing to do, apart from the nature of the job, you're too young to have all these spine issues. So the best thing to do is to review everything carefully and look at X-rays, MRIs, and especially if you're having back and leg pain, there may be some irritation of the nerves that will need to be reviewed. But it doesn't sound like anything dangerous that you should be worried about. It's just probably you have, due to the nature of your job and maybe it's the level of activity, you may have some accelerated wear and tear processes in your spine. But I think some of my people around here, they will be able to tell you based on where you are, where you can see somebody that can help.
Okay, I'm constantly experiencing back pain, even when I'm doing nothing. And when you mentioned about the bladder problem, if I drink a little water, I can go to the bathroom like 6 times in less than 30 minutes. I can't really.
Yeah, so we can review all of that and see what needs to be done.
All right, then.
Mm-hmm.
You're muted,
Hello?
Mr.
Sorry for that. So before we take the next round of people that want to ask their questions directly, we also have some questions here that I quickly want to ask for. Someone says here, please, although now we can't see Prof's video, President is requesting that you kindly demonstrate the best sitting posture while working with laptop to avoid or reduce the back pain. But I'm not sure your video can capture that now. In the meantime, we'll have this other question. Is it advisable to go to a chiropractic treatment during back pain? Because I have seen a lot of videos and I'm worried with the ways they crack bones. Prof.
Well, I think that the lumbar spine segment is is very strong. It has a lot of very strong muscles and big bones, and it takes a lot of force to break it. So in some situations, chiropractic manipulation may help. But I would, again, be very cautious in terms of any chiropractic manipulation in the cervical spine, which is the neck, because it's not as strong, and there's spinal cord and nerves, and the arteries that carry blood to your brain that can be injured in the process of chiropractic manipulation of the neck. Lower back, good. Neck, cautious.
Okay. All right. Please, what can be responsible for knee pain once in a while, Prof?
You're asking a brain surgeon about knee pain. Well, I guess the best I can tell you is that you need to see an orthopedic surgeon or somebody who can actually review it and see what's going on.
All right. Very quickly, I have a back pain just within 2 days and no more, but extended to my left buttocks and legs till now for almost 3 weeks. I did X-ray 2 days ago and discovered early lumbar spondylosis. Was told only exercise I can do. It's only exercise I can do. Please, is there any other solution?
So, like I said in the presentation, that once you begin to have back pain that then maybe translate to leg pain or concurrently, and the leg pain is persistent, and you have what you call burning sensation, it's probably time to get an MRI. X-ray looks at bone very well, but it doesn't, and it looks at openings in the spinal canal and the foramina, and it looks at them well, but it doesn't tell you what's going on with the nerves. So when you're having leg pain and burning sensation, it just means that there is something irritating the nerves that needs to be looked at, and the best way to do that is an MRI. I know that's not always feasible, but the other thing you can do is, once you've tried the medications and tried some of the other medications I mentioned, when you have nerve irritation symptoms, there's other medications that we call sort of maybe adjuvant or additive medications that can support the mainstay medications, like Lyrica or pregabalin or gabapentin, Cymbalta. Those things, they help to modify the way the nerves fire or function, and those are some medications that could help. Thank you.
All right, sir. Yes, sir. I think the final question that I have with me, based on the ones in the chat box, is please, Prof, what is the relationship between full bladder and lower back pain? Is there any correlation between the two?
A relationship between what bladder?
Full bladder and lower back pain.
A full bladder and a lower back pain.
Yeah. Yes. Is there any correlation?
The nerves that control the function of the bladder and your bowel are coming from obviously the brain, the spinal cord, the conus, and then to nerves to go to those structures. And what you're saying may be completely unrelated, but sometimes when you have significant back pain and you're having difficulty emptying your bladder, then you might, or difficulty controlling urine from coming out, then that becomes something concerning. But typically, that tends to come with some other symptoms in terms of pain in the leg, numbness, weakness, and things like that. But so I think they may be unrelated, but difficulty and full bladder. Again, the other thing to note is that pain by itself, severe pain, can cause people to lose control of the bladder just because of the overdrive of the autonomic nervous system. So, and it can even make sometimes just soil themselves. So, I think everything has to come together for you to say it's because I have back pain and then my bladder is not working. In this case, I think an MRI is definitely very important to be able to see what's going on.
All right. So we have some people that also raise their hands. So I'm going through the second batch of people now. I have Hussein Muhammad. Please, are you there, please?
My question has been answered. Thank you very much.
All right. Okay. I have Tunde Komolafe. Please, you also raise your hands.
Yeah. Good morning.
Good morning.
Yeah, I have. Yeah, I have a question. I know the doctor mentioned using of non-steroidal anti-inflammatory drugs, and as well suggested that if it's not, it doesn't work, you can go to the extent of going the medication for shock. I mean, you're given a steroid. I would like him to have to throw more light on the effect or the side effect of getting the steroid into the system, much as for people who are pre-diabetes.
Yeah, so thank you so much for that question. I think the question was to describe some of the risks and benefits of epidural steroid injection. I think, again, it's one of those maybe tier 2 level of therapy that we use. And the way what it is that if you have an acute disc herniation or you have spinal stenosis or you have something that may be compressing the nerve, and I was saying that instead of taking the medications by mouth and you have to go through your bloodstream to the nerve, we tend to apply it directly on the nerve to reduce inflammation and then control the pain with local anesthetic. Now, for people with diabetes, obviously, steroids can increase your diabetes, your sugar level. Yeah. What we tend to do is, again, it depends on how controlled your blood sugar is. This is a very small dose of steroid, and if it has any effect at all on the blood